If you are listening to this right now, and you went to a doctor complaining of like really deep, agonizing pelvic pain, or maybe a stubborn bladder infection that just won't go away, what do you think they'd look for?
Right, they'd probably check your urine or something.
Exactly. They might schedule an ultrasound. Maybe they'd, look into muscle strains or even appendicitis. But I can almost guarantee you the absolute last thing you'd expect them to ask about is vaginal dryness.
It sounds completely counterintuitive. I mean, most people think of those as two entirely separate zip codes of the body.
Yeah,
You have
totally.
a surface level moisture issue on one hand, and then this like really deep internal ache on the other.
Exactly. So, welcome to today's deep dive. Our mission today is to untangle a medical mystery that affects millions of people, but almost nobody talks about. We are going to answer a question that seems, frankly, bizarre at first glance. Can vaginal dryness actually cause deep pelvic pain?
And, well, the short answer is a resounding yes. But the fascinating part is the biological journey of how it happens. We're talking about a microscopic domino effect that starts with a hormonal drought.
A hormonal drought, okay.
Yeah, and it ends up completely rewiring the chemistry, the musculature, and the bacterial landscape of the entire pelvic region.
It's wild. And to get to the bottom of this, we're diving into a stack of clinical guidelines and research from the NHS, the Royal Australian College of General Practitioners, and the British Menopause Society. And what we found is that the medical community is starting to call this a silent epidemic.
Right, and to really grasp how a lack of moisture on the surface translates to debilitating internal pain, we have to kind of zoom out. We need to look at a broader umbrella condition called genitourinary syndrome of menopause.
Okay.
You'll often hear it abbreviated as GSM.
I want to pause right there, actually, because the name itself gives us our first major clue, right?
Exactly.
We aren't just talking about a single symptom like feeling a bit dry. We're talking about a systemic failure of an entire environment. But before we get to the pain, we really have to understand the root cause of the drought itself. Because if you're picturing someone just, not drinking enough water and getting dehydrated, you're looking in the absolute wrong direction.
Oh, far from it. Yeah. The older medical term for this used to be atrophic vaginitis, but GSM is much more accurate because, like you said, it encompasses the entire genitourinary tract.
Right. So the vagina, the vulva, the urethra, the bladder, all of it.
All of it. At its core, this entire syndrome is triggered by a dramatic drop in the hormone estrogen.
Now, obviously, the M in GSM stands for menopause, so that's the most famous trigger. But looking through the clinical data, I was actually stunned by how many other things cause this estrogen drop. I mean, you could be experiencing this in your 30s.
Absolutely. The sources highlight that while menopause is the primary driver, this estrogen drought can hit you at many different stages of life. The years leading up to menopause.
Perimenopause.
Right, perimenopause can trigger it. Breastfeeding is a huge one, actually,
Mm-hmm.
because the hormone that produces milk, prolactin, it suppresses your ovaries from producing estrogen.
I had no idea about that. And it's not just natural life phases, right? Because medical interventions play a massive role here, too.
They really do.
Yeah.
Pelvic radiotherapy or chemotherapy can severely damage the ovaries.
Mm.
Hormonal cancer treatments like tamoxifen are specifically designed to block estrogen receptors. Right.
To starve breast cancer cells, yeah.
Exactly. But that means they also block estrogen from reaching the pelvic tissues. Surgical removal of the ovaries drops estrogen to zero pretty much overnight.
Wow.
And even conditions like diabetes can trigger this. Chronic high blood sugar damages the tiny blood vessels that supply oxygen and nutrients to the pelvic region.
Okay, so the estrogen drops, whether it's from age, surgery, medication, whatever. What is actually happening at the cellular level? Like, why does the moisture just disappear?
Well, think of estrogen as essentially the master architect and the chief nutrient supplier for the whole female pelvis.
Yeah.
When you have abundant estrogen, the tissue environment is plump, it's elastic, and it's super rich with blood vessels.
Right.
The cells lining the vagina are mostly what we call superficial and intermediate cells. They're thick, they're robust.
But when the architect leaves the building...
The whole structure starts to compromise.
Yeah.
The tissues begin to physically thin out. The body just stops producing collagen and elastin in that area.
Oh, wow.
Yeah, and that dense network of blood vessels literally shrinks and retreats, meaning way less blood flow.
Yeah.
And the very makeup of the cells shifts.
How so?
Without estrogen signaling them to mature, you lose those robust superficial cells.
Mm-hmm.
And you get a marked increase in what are called parabasal cells, which are essentially these small immature cells that just don't provide much of a barrier at all.
Okay, let me make sure I'm wrapping my head around this. Because it's not like having chapped lips where the top layer is just a bit dry.
No, not at all.
It's more like, imagine a thick, sturdy brick wall. Estrogen is the mortar holding the bricks together, and it's also the supply line bringing in new bricks. When the estrogen drops, the mortar dissolves, the supply lines get cut, and suddenly your thick brick wall is just a single, fragile layer of dust that could just crumble if you lean on it.
That is a brilliant way to visualize it, yeah. The foundation itself is compromised. The natural, stretchy folds of the vagina, which are called rugae, they actually smooth out and disappear because the tissue just loses all its elasticity. It becomes thin, pale, and incredibly fragile.
So, okay, now we have a compromised, fragile foundation. This brings us back to our big question. How does this lead to pain, specifically pelvic pain?
Right. Well, the clinical term for painful intercourse is dyspareunia. And to understand the pain of GSM, we have to break dyspareunia down into two distinct categories, superficial and deep.
Superficial sounds like it's right at the entrance.
Yes. Superficial dyspareunia is a sharp, often severe pain felt at the vulva or the lower vagina, usually right at the moment of entry. Think back to your brick wall analogy.
Right, the layer of dust.
Exactly, because the tissues are now so incredibly thin, dry, and lacking any protective barrier. The simple mechanical friction of intimacy causes literal microcuts and tearing in the tissue.
Ouch. That sounds awful.
It's agonizing. It triggers a severe inflammatory response. But that is just the surface level. The sources also talk extensively about deep dyspareunia.
Right, and this is where I was really struggling to connect the dots when I first read the research. I mean, I understand the surface tearing, but deep dyspareunia is felt deep within the pelvis.
Yes.
The sources describe it as an ache that can radiate to the front or even down the inner thighs, and it can last for hours after the physical trigger has stopped. So how does a dry surface cause an ache deep inside the body?
This is where we have to look way beyond the skin. Estrogen doesn't just act on the surface lining of the vagina. It acts on the entire musculature of the pelvis.
Right, estrogen affects the muscles. I had no idea.
Deeply. The muscles, ligaments, and fascia of the pelvic floor rely heavily on estrogen to maintain their collagen levels. Think of your pelvic floor as, like, a supportive trampoline.
Okay, a trampoline.
Yeah, it's a hammock of muscle that holds up the womb, the bladder, the bowel, literally everything.
Okay, so if the trampoline relies on estrogen to keep its bounce.
When the estrogen drought hits, that collagen breaks down. The trampoline loses its elasticity. It starts to sag and weaken. This leads to profound pelvic floor dysfunction and sometimes even prolapse.
Prolapse, like things falling.
Literally, the internal organs begin to shift downwards because the muscular support has given way.
Oh, wow. So if you're experiencing deep pelvic pain during or after intimacy, it might not be the mechanical friction causing it at all. It's the physical strain on a weakened muscular trampoline that is just failing to support the organs.
Precisely. You're putting physical pressure on a muscular hammock that is already strained, structurally weak, and completely lacking its normal cushioning.
That is what.
And that muscular fatigue and structural shifting translates to a deep, radiating ache that lingers long after the physical activity has stopped.
Man. So we've got the physical side of the domino effect, the microcuts from the fragile cells, and the deep muscle ache from the sagging trampoline. But the physical changes aren't the whole story, are they? Because the sources point out that this mechanical dryness triggers a massive chemical chain reaction.
It does. And this chemical shift causes a completely different type of agony. It all comes down to the microbiome.
See, we hear constantly about gut health and the gut microbiome, but you really don't hear much about the vaginal microbiome.
You don't, but it is incredibly sensitive and highly calibrated. In a healthy premenopausal state, the estrogen in your body tells your vaginal cells to store a sugar called glycogen.
Okay.
And as those healthy, plump cells naturally shed, they release that glycogen into the environment.
Okay, so you have an environment full of natural sugars.
Right. And those sugars are the primary food source for the good bacteria in the vagina, specifically a strain called lactobacilli.
Lactobacilli, got it.
These good bacteria eat the glycogen and produce lactic acid as a byproduct. That lactic acid keeps the entire vaginal environment nicely acidic, usually around a pH of 3.5 to 4.5.
Which is like the acidity of a tomato or a cup of black coffee, right?
Yeah.
And I'm assuming that acid acts like a shield.
It's the ultimate defense mechanism. Most bad invasive bacteria simply cannot survive in an acidic environment like that. But think about what happens when the estrogen drops.
Okay, so the estrogen drops, so the cells stop producing glycogen,
The glycogen disappears completely.
which means the good bacteria starve.
The lactobacilli just die off.
Yeah.
And without them producing lactic acid, the pH level of the vagina violently skyrockets. It goes from being a protective acidic shield to a highly alkaline environment.
How alkaline are we talking?
Well, one of the clinical sources we looked at literally compares this new alkaline state to caustic soda.
Wait, caustic soda, like industrial drain cleaner.
Chemically, yeah, it's a very similar type of high alkalinity. Now, obviously, it's not actually drain cleaner, but the biological impact on those fragile tissues is severe. That high pH causes intense chemical irritation, burning, and constant itching, even when a patient is just sitting perfectly still.
Wow. It's like, imagine you have a beautiful garden. The soil pH is perfectly balanced. You've got great grass growing, which keeps all the weeds out. But suddenly, the soil pH spikes. The good grass dies. And because the protective grass is gone, the invasive, thorny weeds immediately take over the yard.
That is exactly what happens.
Right.
Because the acidic shield is gone, pathogens that normally couldn't survive suddenly realize the doors are wide open. Bacteria from the gut, like E. coli, they migrate over and set up camp. They absolutely thrive in this new alkaline environment.
Okay, but how does this weed invasion cause the deep pelvic pain we're talking about? Like, I get the surface burning, but the deep pain.
Because the garden isn't isolated. It shares a property line with the bladder. The bladder and the urethra, which is the tube that carries urine out of the body, are situated right next to the vagina. And here's the kicker. The tissues of the urethra and the base of the bladder are packed with estrogen receptors, just like the vagina.
Oh, no. So they thin out, too.
They do. Without estrogen, the urethra's lining becomes incredibly thin. The mucosal seal that normally keeps it tightly closed becomes weak.
So you have a weakened doorway sitting right next to an environment that is suddenly swarming with invasive E. coli.
It is a total recipe for disaster. The bacteria have a direct, undefended pathway straight up into the urinary tract. This is why women with GSM experience severe, recurrent urinary tract infections.
That makes so much sense.
But it goes beyond just UTIs. The thinning of the bladder wall itself makes it hypersensitive. We are talking about urgency, feeling like you have to go right this second, frequency, and dysuria, which is painful, burning urination.
And the sources also mention something called interstitial cystitis.
Yes. Interstitial cystitis is a chronic, agonizing inflammation of the bladder wall. Because the protective mucosal layer of the bladder is compromised by the lack of estrogen, the actual urine inside the bladder, which is acidic and full of waste products, can seep into the bladder wall and irritate the nerves directly.
Which feels like deep pelvic pain.
Exactly.
If you were a patient, you might just feel this terrible burning ache deep in your pelvis. You think your bladder is failing, but the actual root cause is that your estrogen dried up, which starved your good bacteria, which spiked your pH, which invited in the E. coli, which invaded your weakened bladder.
It is an absolute masterclass in how interconnected the human body is. You simply cannot treat one system while ignoring the one right next door.
Okay, so we have established a terrifyingly massive physical and chemical impact here. We've got microcuts, a sagging muscular trampoline, caustic soda pH levels, and relentless bladder infections.
Yeah.
If this is happening to so many people, why on earth isn't this front page news? I mean, the sources refer to it as a silent epidemic. Why is it silent?
The statistics really illustrate the tragedy here. Genitourinary syndrome of menopause affects up to 80% of postmenopausal women. 80%.
Wow.
Yet research shows that only about 7% actually seek medical help for it.
80% are suffering, and only 7% ask their doctor for help. That gap is just staggering. What is stopping them?
It's a deeply ingrained mix of ageism, medical gaslighting, and embarrassment. There's this pervasive cultural assumption that these debilitating symptoms, the painful sex, the urinary incontinence, the constant burning, that they're just an inevitable, normal part of getting older.
Right, like you just have to deal with it.
Exactly. People think they just have to suffer in silence. And because the symptoms are so intimate, patients are understandably embarrassed to bring them up in a brief, 15-minute doctor's appointment.
And if the patient doesn't bring it up, the doctor might not ask.
Exactly. If you go to your GP complaining of a UTI, they test your urine, write a prescription for antibiotics, and send you on your way. They're treating the symptom, not the structural collapse that caused it.
Oh, wait, I have a question about the treatment side of this.
Sure.
Let's say a patient is already taking systemic HRT, like hormone replacement therapy. They wear the estrogen patch, or they take the pill every day to manage their hot flashes and bone density. Doesn't that systemic hormone automatically travel down and cure the vaginal dryness and the pelvic floor weakness?
Well, you would logically think so, right? But the clinical data throws a major curveball here. The sources note that surprisingly, 10 to 25% of women who are on systemic HRT still require localized treatment for GSM.
Wait, why? If the estrogen is literally in their bloodstream, why isn't it reaching the pelvis?
It comes down to how the body metabolizes hormones and the density of receptors in the pelvic area. When you take a pill, it has to pass through the liver, which is the first pass metabolism, which alters it.
Okay.
Even with a patch, the systemic dose required to prevent a severe local tissue atrophy in the pelvis is sometimes higher than what is safe or necessary for the rest of the body. The systemic hormones just aren't concentrated enough to rebuild that specific urogenital scaffolding.
Okay, so if someone falls into that 25% category, or if they aren't on systemic HRT at all because of personal choice or medical history, what do they do? How do you actually fix the trampoline, lower the pH, and stop the pain?
The medical guidelines outline a very clear, stepped approach. You usually start with non-hormonal options. These are things you can get right over the counter. You have vaginal moisturizers, which are designed to be used every few days. They often contain things like hyaluronic acid, which binds to water and restores moisture to the tissue.
And what about for the mechanical friction during intimacy?
For that, water-based lubricants are recommended right before activity. But it is vital to read the labels. The sources are very strict about avoiding petroleum-based products like petroleum jelly, primarily because it breaks down latex condoms and can actually trap bacteria.
Right, but let me push back on those non-hormonal options for a second. If I use a moisturizer, aren't I just putting a Band-Aid on a broken foundation? Like I'm making the surface wet, but I'm not rebuilding the collagen or bringing the blood vessels back.
You've hit the nail on the head. Moisturizers and lubricants make things significantly more comfortable. And they can prevent the micro tears, but they do absolutely nothing to reverse the underlying cellular changes of GSM. To actually rebuild the foundation, the gold standard medical treatment is topical vaginal estrogen.
Ah, so this is putting the architect right back into the building.
Yes, it delivers the estrogen exactly where it's needed without flooding the rest of the body. And it comes in a few forms. There are estrogen creams you insert with a small applicator. There are tiny vaginal estrogen tablets. And there's a fascinating option called an estrogen ring.
Wait, how does the ring work?
It's a soft, flexible silicone ring that you insert high into the vagina, much like a tampon. It sits there comfortably and slowly, consistently releases a microdose of estrogen directly into the tissues over the course of 90 days.
Wow, and what happens when those tissues get that localized estrogen?
It's literally like watering a dying plant. The estrogen binds to the receptors in those tiny, immature parabicel cells. It signals them to start dividing and maturing again. Over a few weeks, the tissue plumps back up into thick, protective superficial cells.
Oh, that's amazing.
Yeah, the body receives the signal to rebuild the collagen matrix. The blood vessels return. The glycogen comes back, which feeds the lactobacilli, which restores the acidic pH, which kicks out the E. coli.
It literally reverses the entire domino effect we just spent 20 minutes talking about.
It does. It is remarkably effective.
No, I do have to bring up the elephant in the room here.
Oh, I know what you're going to say.
Yeah, whenever the word estrogen is mentioned as a treatment, a lot of people listening are immediately going to worry about the risks, specifically the link to breast cancer.
It is the single most common fear patients have. And it is completely understandable given the really confusing history of hormone therapy reporting over the years. But the guidelines we are looking at today, including those from NICE, which is a gold standard for clinical care in the UK, they are unequivocal on this.
What do they say?
Topical vaginal estrogen is an incredibly low dose. Because it is applied locally to the tissues, it acts on those local receptors, and an almost undetectable amount actually reaches your overall bloodstream. The clinical guidelines clearly state that these localized low-dose treatments do not carry an increased risk of breast cancer for users.
Okay, that's huge. Even so, I noticed the sources mention a specific caveat. If a patient has a personal history of hormone-sensitive breast cancer, they shouldn't just start using this on their own, right?
Correct. If you have a history of hormone receptor-positive breast cancer, you should always consult your oncologist before starting even topical estrogen, just to ensure it perfectly aligns with your specific cancer treatment plan. But for the vast majority of people, topical estrogen is a safe, highly effective way to rescue the pelvic floor and stop the recurrent urinary infections.
But it's not a one-and-done cure, is it? Like, you can't just use a tube of cream and be fixed forever.
No, it definitely requires maintenance. Usually a patient will use a daily dose for about 2 weeks to aggressively rebuild the tissue and then transition to a maintenance dose maybe twice a week indefinitely. If you stop the local estrogen, the architect leaves the building again, and the symptoms will eventually return.
Right, the drought comes back. Let's take a step back and look at the whole picture here. We started this deep dive with a question that felt like a riddle. How does a dry surface cause a deep, agonizing internal ache? And the answer took us through an absolute masterclass in human anatomy.
We saw that the dryness isn't just a lack of water, it's a total structural collapse driven by an estrogen drought.
Right. It alters the cellular makeup, thinning the walls to paper. It degrades the collagen in the pelvic floor muscles, causing the organs to sag and strain. It completely rewires the body's internal chemistry, changing a protective acidic shield into a burning alkaline wasteland.
Yeah.
And it invites in a swarm of invasive bacteria that trigger a cascade of deep pelvic and bladder pain. It is completely, flawlessly interconnected.
Which leaves us with a final thought for you to mull over today. Think about the danger of treating the human body in isolated, specialized silos.
What do you mean by that?
Well, imagine a patient who goes to a urologist for her recurrent UTIs and then goes to a pain specialist for her deep pelvic ache. She gets given antibiotics for the bladder and muscle relaxers or painkillers for the pelvis. But because she is too embarrassed to mention her vaginal dryness, or because the doctors are only looking at their specific area of expertise, the actual root cause, the silent epidemic of GSM, is entirely missed.
Right. The dashboard warning light is flashing in the bladder, but the actual engine failure is happening in the estrogen levels.
Exactly. It highlights how absolutely vital it is for both doctors and patients to view the body's systems as a completely linked ecosystem.
Breaking the silence around intimacy and dryness could quite literally be the key to curing someone's chronic, agonizing pain. It turns out that straight line of cause and effect we are all looking for when we hurt, it exists. You just have to know how to follow the chemical trail to find it.